on with Dr. Denis. Dr. Denis Romanov from the Center of Innovations, Medical Technology, Russian Federation. Dr. Romanov has completed his PhD at the age of 32 years from Blockins National Medical Scientex Center of Oncology, Russian Federation. He is the head of the Scientific Activity Department of Center of Innovative Medical Technologies since 2029 and head of the Radiation Oncology Department of Central Clinical Hospital of Russian Redways since 2020. He has 69 publications in Russian and foreign medical magazines and 63 oral presentations. So, Dr. Denis, we are listening to you.
Thank you very much, dear friends, dear colleagues. Thank you for the honor and for the pleasure to report in your wonderful conference and to let you know our results in such interesting theme like stereotactic radiotherapy in the treatment of colorectal cancer liver metastasis. My apologies, my English is not perfect, unfortunately, and I use it rarely, then it will be good, but I'll try to be rather understandable, if it's possible. Thank you. We know a lot of, I think, about stereotactic body radiation therapy and treatment of colorectal cancer patients, even with metastasis in liver. And we've got rather many articles, rather many studies, reports about it. And we know that local control after SBRT in colorectal cancer patients is worse than in non-colorectal cancer patients, but overall survival after this treatment, and not only this treatment, and after surgery of metastatic colorectal cancer patients is better than in situations of such diseases like metastatic breast cancer or metastatic pancreatic cancer or melanoma. So it's direction of radiation therapists, radiation oncologists work to treat such patients. We know that worse local control in the colorectal cancer patient is a genetic background. We've got some studies about it, and we understand that it's predicted with some genetic situations. We know from different works that neoadjuvant chemotherapy before stereotactic body radiation therapy negatively affects the local control. Two big works, for example, by Clement and Rashke. We know that there is positive effect of fraction and course dose and negative of volume or size of lesions. Then, for example, interesting that give us answer on the question, can we use, for example, surgery and stereotactic body radiation therapy in these patients, with metastatic liver disease from colorectal cancer? Yes, we can use it, and we know that it's rather safe and rather effective. Then interesting direction of our future investigation is the role of gene mutations, for example, in KRAS or TP53, that can negatively affect local our results. We've got 150 patients. I think it's rather big count because many of these reports are with over count of patients. 16 males, 55 females, median age 65 years. And in these 115 patients, we treated 182 metastases, different of size and different of count in the liver. We used 3 fractions with fraction dose from 10 to 20 grams, and you can see they were developed in different groups with different doses. And I want to ask for your attention to 2 different cohorts: low dose group and high dose group. I will explain later why. We need to understand that there weren't ideal patients. For example, we can see prevalence of the metastatic disease. We can see that 45 patients had got metastasis outside the liver with the prevalence of lung metastasis, but a big count of lymphatic nodes metastasis or peritoneal metastasis. And the second important point is that there were patients where we treated not all metastasis in the liver. Yes, 86 patients got treated metastasis in the liver, but some got untreated active or treated inactive metastasis. I will try to explain what it means. For example, if we have a patient with after chemotherapy and some of liver metastases are growing despite of chemotherapy treatment, but other metastases are stable or with partial response, we can call them inactive. And if we see the patient with a lot of growing metastasis, for example, or if we find untreated metastasis in the control MRI, we can call them active. Our group of patients was pretreated and sometimes and often heavily pretreated. For example, you can see a lot of patients with liver resections, even 3 resections or 4 resections. And this surgical treatment was provided in different time before stereotactic body radiation therapy, from 1 month to a lot of years. 41 patient has got hemihepatectomy. Some patients got stereotactic body radiation therapy, some radiofrequency ablation, some embolizations of hemiembolization, and even one treatment got intraoperative radiation therapy with liver resection. We can see that our patients have got a lot of therapy lines before stereotactic body radiation therapy. And some metastases were recurrent after resection, some after radiofrequency ablation. I know that a lot of my colleagues, they think that you do not use stereotactic body radiation therapy with any chemotherapy treatment. Because they think that it's unsafe or something like else. But we think that it's rather safe. We didn't see any extra toxicity with this combination of treatment. And so we used a lot of different schedules of systemic therapy, of chemotherapy, even rather aggressive. And you can see these schedules here. And in 2 patients after SBRT, we used pembrolizumab immunotherapy because of microsatellite instability high status of their tumors. It's rather interesting when we want to get so-called abscopal effect. Late toxicity, I think rather not very seldom, but in some not so much patients, only 8%. Yes, we see some stomach ulcers, and one patient unfortunately died with stomach ulcer, with recurrence of stomach ulcer after 2 years after stereotactic body radiation therapy. But other problems weren't so big. For example, fibrosis, fibromyalgia, hydrothorax. Um, the problem is vertebral compression fracture, yes, because of pain. But rib fracture was not associated with pain syndrome. And we saw some cases of exacerbation of esophagitis, gastritis, cholecystitis, but they were treated with medication and cured with medication with no future problems with these organs. Then our results. Overall survival. I think it's rather good results with median close to 41 months because we must to remember that it's rather heavily pretreated patients with some of them with big spread of disease, big prevalence. If we divide patients into different groups, we can see that theory of oligometastatic disease is working. We can see that when we treat all detectable metastases, yes, we get the best results with overall survival. And if we, for some reason, cannot treat all metastases in the liver or outside the liver, we get the worst results. And if we treat only with radiation therapy or with our other different methods of local or systemic treatment, if we treat all metastases, the results are rather good too, and there is an evidence in these results, strong evidence. Then local control. I think results are rather good with something like 80% local control in 1-2 years, and then but the group wasn't very but the group of patients was variable, so there are the reasons that the local control is not 90%, for example. Let you see why. If we use high dose SBRT and if we use low dose SBRT, we get different results. We get different local control, and the evidence is strong, and we can see it with this picture. Then, for example, if we study the low dose group, and if we divide it to groups of 45 grays or 30 to 36 grays, we can see different results too. So the dose is an important part of local control result in such patients. And if we divide the low dose group onto 2 different groups, good response to neoadjuvant treatment and bad response, we can see statistically strong difference between local control and these subgroups. I'll try to explain what I mean. Often we have some treatment before stereotactic body radiation therapy, for example, chemotherapy. So we can get different results from such neoadjuvant chemotherapy. On one arm, we can see partial response or stabilization of disease. On the other hand, we can see even new metastases. or growing metastasis. So we understand that this chemotherapy in such a situation give no effectiveness that we want. And if we use low dose stereotactic body radiation therapy for metastasis with effect from neoadjuvant treatment, we get better local control, we get better results. If we use it when we see growing metastasis or new metastasis, we get worse results. And so we can see that it's statistically proved. So our conclusions. I think a lot of doctors, a lot of physicians all over the world have already known that stereotactic body radiation therapy is one of the good options for the elimination of colorectal cancer metastasis in the liver with good rates of local control. We know that this method has logical and predictable safety, so we can see the patients that can have some problems after stereotactic body radiation therapy. For example, connected with localization of metastasis, for example, close to stomach or duodenum or some other critical organs. We know, I think, that this method seamlessly combines with other methods, local and systemic, but we need new studies to understand the best place of stereotactic body radiation therapy in combination with chemotherapy, in combination with surgery. It's rather interesting. I think it's our future to use a lot of different ways to eliminate all metastasis in liver or outside it. We think that the ideal dose is ideal course dose is 54 grays. We think that 60 is too much because of often necessary to do to repeat stereotactic body radiation therapy to new metastasis after first or second treatment. And we can see that low doses are not so effective and give us worse results, worse local control. But if we use them, I think we have to try to reduce lesions to get some anti-tumor effect with chemotherapy or other different local or systemic treatments. Thank you for your attention, dear friends.
Thank you very much, Dr. Romanov. Is there any questions to ask Dr. Romanov?
Yes, I have a question.
Okay. Go ahead.
Thank for Dr. Denis. Can you show the figure 2, the slide figure 2? Figure.
This one?
Yes. Here we see the line cross each other, and in this situation we cannot use Cox regression or other tests to show p-value. And here we can use the AFT models or Cox piecewise models. Maybe is better. And I think the next. Can you show the next figure? The next slide.
Yeah. The
next. Here here we see p assumption is not met, and I think the p-value may be wrong. And I recommend you to use piecewise Cox. Maybe you compare the patient less than 1 years separately, because after that, the line be parallel. I suggest you use another method for comparison groups, because when the assumption of analysis violate, the p-value may be not valid. And then in my lecture, I pay attention to this importance note. Thank you.
Okay, thank you very much. It's very important for us to become better and use the better way to analyze our results and to use our results in our professional growing. Thank you very much.
Thank you.
Any other questions? I think it's okay, Dr. Romanov. Thank you.